Well, hi everyone. I'm Dr. Shaz Mithani, an emergency doctor.
And I'm Dr. Sheila Wijayasinghe, family doctor.
And welcome back to the Doc Talk podcast. So last week was our first episode. We had a chat about respiratory viruses. So Sheila, I just wanted to check in to see how you've been doing before we introduce this week's topic.
Well, by chance, the respiratory viruses have hit our home now. My son came to our bed last night at 11 p.m. and I ended up sleeping with him just to get him through the night. So we're in the season. And actually, I hope everyone can take a listen to that episode because we talked about some really interesting ways of supporting your kiddos and yourself. And we started doing the saline rinses yesterday to help him out. So learn more, check out our previous podcast and you can see what we're talking about. But yeah, I'm a little tired today.
Yeah, I bet. Yeah, same here. In our household, we definitely have some respiratory viruses going through as well. But this week, we're so excited to talk about the focus of our week, which is perimenopause. So we will talk about what it is, what the symptoms are, early versus late perimenopause, what the differences are, what age it can start at. I certainly have those questions. And of course, what options are available for support and different things that you can do in terms of lifestyle, hormonal and non-hormonal options as well.
Amazing. This is my favorite thing to talk about these days. I just recently got my menopause certification. It's really something I try to focus on in my practice as well. So I'm thrilled that we are discussing it because it is something that's so common. So as discussed, we're going to start every episode with a caller question. And today we have the incredible Melissa Grelo. She is the host of The Social. She created and stars in her own podcast, Aging Powerfully with Melissa Grelo. And she's phenomenal in raising awareness and advocacy around access to care and perimenopause and menopause. So take a listen to her question.
Hey docs, it's Melissa. Listen, I get a lot of questions from women wondering, am I in perimenopause? Now, some are saying that doctors just tell them it's part of aging and there's nothing to be done. What would you say to these women? Is there anything that they should be asking or doing differently?
This is such a great question. This honestly feels like it could have been me. So today we're actually going to have a little bit of fun with the structure of our episode. Since I'm now 40, almost 41, I actually wonder if I am having some symptoms of perimenopause. So we thought we'd structure this episode like a patient talking to Dr. Sheila, who is going to be my provider and the expert in perimenopause and menopause. So Dr. Sheila, I've been hearing about perimenopause everywhere, and I'm honestly starting to wonder if some of the symptoms that I'm having could be related to perimenopause. So can you tell us exactly what perimenopause is?
Yeah, absolutely. So again, one of my favorite topics because I'm also in it. So I'm 46. I know that I'm fully into this phase of my life. It's a phase that we will all experience if we are born with ovaries. And so generally what happens, menopause we know is the time where we stop having periods, and the average age in Canada is 51. Perimenopause is the time leading up to menopause. And that can happen 10 years before you actually go through that change. And so for folks, it's surprising to hear that number because even in your late 30s to early 40s, you can start to have these changes where we start to ovulate less frequently. And as a result, we are having changing levels of the key hormones of estrogen and progesterone. They often go down, but they can actually fluctuate quite a bit. And the way we describe it to our patients, Shaz, is that it's like a roller coaster where one time you might be up on their cycle and you might have extra estrogen compared to normal. Other times you might be really low. And so it really fluctuates up and down. And it can fluctuate for several years for people. And when we see those fluctuations, that results potentially in the symptoms that we see. So we commonly know that people may feel a bit more tired. They may have changes in their mood, breast tenderness. Those symptoms generally are related to when we're in the higher estrogen time where you might be going up and down, but higher estrogen. And then when you go down in estrogen levels, that's when we see the typical symptoms of menopause, like vasomotor symptoms, which are the hot flashes and night sweats, and also the sleep disturbances. So really, it's a time of large change physically, emotionally, and it can be really hard to navigate. And often, as Melissa had said, so many women are told there's nothing we can do. This is just aging. But what we're here to discuss today, and I'm so glad that we're talking about it, is that there are things that we can do.
And so, you talk about these cycles of going up and down, like kind of leading into menopause, which is where the hormones kind of pull back, so to speak, as the ovaries stop kind of producing those hormones. So like, are those cycles predictable in this phase, or is it pretty random?
No, so it can be really random. For some people, they are predictable. So everyone's really different in this stage, which is also why it's really important to have these individual discussions with your own healthcare providers, because your symptoms may be very different than somebody else's. And so it is, but the hallmark feature is that we see changes in period length. And so your cycles may go from being a regular 28-day cycle between each period to maybe once every 21 days. For some folks, their cycles shorten. For others, the cycles lengthen out and they might go every 35 days or longer. And we start to see those changes. And in association with that, but then we might get the other symptoms as well, as I mentioned, with the estrogen changes and the progesterone changes as well. So the period changes are really a hallmark feature of perimenopause. For some folks, if they're on birth control, they have an IUD, they may not be cycling in the same way. And so we may not know if you're in perimenopause based on your period alone, but we base it on your symptoms then. So are you noticing the changes in sleep, mood, hot flashes? And that gives us a good clue.
So one of the things that I often see in the social media space and kind of beyond that is lots of different types of providers saying that there are tests that you can do for perimenopause, like to check your hormones and to decide if you're like in perimenopause or in menopause. And so is there like a blood test that can be done or some sort of test that can be done to diagnose it? I've also heard of some like over-the-counter pregnancy test type tests that you can buy to predict menopause. Like, is there a test? Are these accurate, or how is it like definitively diagnosed if possible?
Such a good question. You know, menopause, perimenopause, this space is huge right now in social media. It is a multi-billion-dollar industry, and test kits and doing things like the Dutch test, it's called, those things are not validated to actually tell us anything because, as I mentioned, there is a large fluctuation of hormones happening, and day to day that fluctuation happens. So if we test you on this day, it may be very different than the next day. And so it's not giving us very good information. So doing a test and paying money for that test is a waste of money. And I suggest first what you do, instead of doing these tests, especially if you're over the age of 45, that's around the time that we'd expect to see these changes happen. For folks under the age of 45, or you may be having other symptoms, it really draws the important point of we have to test for other things too that might be causing these symptoms. The pendulum is swung from never talking about menopause and perimenopause to now saying everything is due to perimenopause and menopause. And I think that's an important point that I think we need to make here, is that there's other things like thyroid issues, iron deficiencies, other hormonal abnormalities, that sleep apnea, heart disease, that can all mimic the symptoms as well. So if you are going to be doing a test, you may not get a very accurate picture, but what the key point is that don't spend money on it, but we do need to rule out other things as well, especially if you're younger than what we'd expect.
Yeah. So the Dutch test, is that something like, what does it test for? Or what is it testing for?
Yeah. So they're testing for things like your follicle stimulating hormone, or FSH. That's the key one that people are testing for. There is value in that test. So for my patients who are younger than 45, and especially if you're younger than 40 and you're noticing changes in your cycle, I am going to check that, but you don't have to pay money to do that. That's covered under healthcare plans for me to be able to order that test. If it shows that that number is high, it means that maybe there is something happening with ovarian function and you're having decline, and you have a high level of FSH, which is usually associated to a low level of estrogen or estradiol in your blood. And so I'm going to retest you again and see, where is this pattern going again? Because remember that roller coaster happening. A one-time test isn't going to tell us very much, but we need to track it. And so the Dutch test is often done to give people information. And I think one of the challenges, Shaz, is that people have been turned away from the healthcare system so often when it comes to care in midlife that they're looking for answers and support. And we have done a disservice in the healthcare system, in our family medicine offices and otherwise, in saying there's nothing we can do. And as a result, people are going to other providers to get answers, and they're doing these tests. These tests cost $700, $800, $900.
Wow.
And it's really sad because they don't tell us very much again. How we treat symptoms isn't based on a number that we get out of your blood work. How we actually treat your symptoms is based on how you're feeling once we intervene with some form of lifestyle or treatment option. And then we evaluate you, not based again on number in your blood work, but how you're feeling. And so doing those tests don't help that much.
Yeah. And I think you brought up two really important points there. I mean, one being that these are tests that you might do, or these are hormone levels that you might test for, but you're doing them so that the patient doesn't have to pay for them, but also it means that you're connected with an actual expert who can interpret that data with you, can interpret it in the context of the symptoms that you're experiencing, and then come up with an individualized plan for you, right? And so I think that's a really important point to keep in mind. And then the other piece that you mentioned that I think is so important is the chronic underfunding and undervaluing of women's health in medicine, right? That has been something that has happened well before our time as physicians, is continuing to happen. And I think the pendulum is swinging, like you said, where I think now that, women are feeling empowered to have a stronger voice in their own health, that my hope is that will translate to increased awareness, increased research, and increased funding in different women's health topics, because we are 50% of the population or more, right? And so this is such an important piece to continue to put funding and to put resources towards 100%. For sure.
We are over 50% of the population, and 8% of funding currently goes towards women's health research. And so that needs to change, and we're advocating for that change to happen. I think it will. But with that, we're learning more as we go. And so I always tell my patients, I'm like, listen, menopause is evolving and we're getting more information. There's more we can do for you, and stay tuned to this space because it's always going to be evolving because we need more research.
Absolutely. And, I think historically when we think about menopause, certainly our mothers, right, were like, oh, well, it's just hot flashes. But clearly what I'm hearing from you and certainly what I've been hearing in kind of in this space is that it's not just hot flashes. There's a lot more going on than that. And women can experience a lot of other symptoms like you mentioned. And so how can women navigate these symptoms, especially when it's affecting our day-to-day lives like work? I mean, I'm a mom, you're a mom, right? Yeah. We have careers, we have other interests that we're doing as well, and trying to kind of manage the household and work and balance all these other things while trying to navigate these symptoms. What do you kind of recommend for people who are going through this?
Yeah, I mean, there's over 40 plus symptoms of perimenopause and menopause, from, the typical symptoms of hot flashes, like you mentioned, sleep disturbances, mood changes. You can also get increased anxiety. We notice that ADHD becomes unmasked during this time for some folks. Fatigue. There's the joint pain. Some people get tinnitus or vertigo as well. You've probably seen that when they emerge. Yeah, there's just so many changes because we have estrogen receptors throughout our whole body. And so as a result, we do see these changes, especially with, again, that roller coaster. I say roller coaster several times today because that is what perimenopause is. Being in myself, I know it, right? Like it's really hard for patients. Plus, in midlife, we are navigating, as you said, all of these different roles. So you're caught between perhaps parenting, caring for aging family members. You're at the peak of your careers. We know the Menopause Foundation of Canada has done incredible landmark studies on this, and they say 1 in 10 individuals will leave the workforce because of unmanaged symptoms. Wow. And that is huge. And that is something that we don't have to live with. We can actually get support. So the main things that we do to support my patients when I'm working, so if I'm seeing you in my office, Shaz, I would start with things like knowing your numbers, because we also know that risk factors in perimenopause for heart disease and osteoporosis, those things increase as well. So we're going to check your blood pressure, we're going to do your blood sugar, check your cholesterol. And then we focus on lifestyle changes as a first step, often looking at your sleep quality, managing your stress, suggesting regular exercise, like 150 minutes a week of moderate exercise in cardiovascular, plus 2 strength training exercises a week. If you can manage that, that really helps with our bone density and our muscle strength. And then we also look at things like non-medication options and things like non-hormonal options, because there are options available in perimenopause for support, and hormonal options as well. I think we have guidelines around menopause care and menopause hormone treatment. We also can use those options in perimenopause, and there's different nuances around how we do that. So there's a whole plethora of options that are available. When we talk about hormonal therapy, often people will be like, well, I don't want to take the pill, so I don't think I can take hormonal therapy. The birth control pill, for example, has several times higher doses of estrogen, and folks who may not be able to tolerate the birth control pill can actually tolerate menopause hormone therapy because it's a much lower dose. Okay. So I just bring that in because I think sometimes my patients, especially folks who may not be able to take a pill, like those who have migraines with aura, a history of blood clots, especially specifically the estrogen component of the pill, can actually safely take estrogen-containing hormone therapy for menopause as well, because it's a lower dose. We just have to consider different formulations for safety reasons. So I think there's just so many different options, and we can definitely get into that a bit more.
Awesome. Thank you. I do want to take a brief moment to thank our sponsor for this episode, Always Discreet. You coughed or laughed or sneezed too hard and whoops, there it is, a bladder leak. I know this is something I'm not going to be shy. I'm not going to be shy. I definitely do experience bladder leaks here and there.
Me too.
Whether it's, powering through that final workout rep, unexpectedly I can have leaks if I'm when I'm playing Frisbee, if I'm diving for a disc, I definitely have to be careful. I always try to pee before I'm playing sports. Hearing from you clearly, we're not alone in this and there's no need to worry. Always Discreet is here for these situations. Many women do experience urinary incontinence as they go through perimenopause and menopause, and nearly half of us may encounter these leaks or accidents during this time. By the age of 65, about 75% of women report experiencing some form of urinary leakage. And it's a topic that we're rarely discussing because I think there is some shame and embarrassment around it for sure.
For sure. Always Discreet has a rapid dry core lock, and it helps to keeps away even the biggest leaks with no wetness or odor and no visible lines, allowing you to stay active and confident. They stay in place comfortably and remain invisible under clothing. So if you're interested in learning more about this, you can please check out our link in our show notes for an Always Discreet coupon code. And we really appreciate them supporting our podcast because this allows us to get more information to you. It's really interesting because it actually brings up, Shaz, the topic of genital urinary syndrome of menopause, which is one of the symptoms that we don't talk about enough, as you mentioned, because of shame. And genital urinary syndrome of menopause affects the vaginal tissues, the vulvar tissues, the clitoral tissues, and urethra and bladder and pelvic floor, because estrogen feeds those tissues. And in perimenopause, so the time even before menopause itself, you may start to notice changes. So I like you mentioned, you've noticed that change as well. We've had kids as well. That affects our pelvic floor. That's happening more commonly when I'm coughing or sneezing. That also happens. There are options for support. Working alongside a pelvic floor physio can be helpful, but one of the treatment options that we can use that is underutilized is vaginal hormonal therapy, which is local estrogen therapy that helps to feed the vaginal tissue, the urethra, and it helps with the vaginal microbiome and reduces the risk of things like UTIs and incontinence, and also supports pain with sex is a common symptom that people get with vaginal dryness, and that's something that we also do. So that's just a little quip that I want to make sure that we address that too.
Yeah, it's great to know that there are a lot of options out there. One of the things that we were talking about is navigating not only life, but the workplace, right? And so having perimenopause symptoms as a professional, we are two professional working moms, it can be really challenging. So in terms of strategies, are there any strategies you can recommend for taking to employers or for managing the symptoms throughout the workday when you are, in a busy career and really trying to hustle and get through the day?
Yeah, I do a lot of work for workplaces around this. There are menopause-friendly workplace guidelines that are available through the Menopause Foundation of Canada. So if your workplace doesn't have that yet, you can go to their website and find the actual document that has a checklist on it on how to make menopause-friendly spaces at work. And they offer options like some places have brought in making sure people can have adjusted flexible timelines. So, and I do that with my patients as well. So if someone is struggling to do their regular 9 to 5, they can start. One of the benefits of the pandemic is that we've been able to adjust our schedules a little bit if we're working from home or not. Now, if that's available to you, I write letters to say, can we do an accommodation while we're trying to manage the symptoms currently? I don't have to say what it is that we're managing, but I just say, there's a medical issue happening. Those are the unmanaged symptoms of menopause. And I write a letter to say, this person, I'd like them to be able to work from 10 to 6 instead of 9 to 5 because if they haven't been having a good sleep pattern, for example. So that's a really practical way that you can get that support. We always talk about the other things around, getting the treatment, also dressing in layers, fans, those kinds of things that women know what to do. But I think one of the key pieces in workplaces is that we're opening up the discussion. Taking that resource from the Menopause Foundation is really important. We make up a really important part of the workforce and we are valuable. And just because we're not having periods doesn't make us invaluable anymore, which is what people often feel. And I think if we can talk about this more and get that support and talk to your doctor or clinician about this to get treatment for your symptoms, we'll be able to address things to keep you at work. This is variable, of course, depending on where you do work, of course. There's certain places like factories and other spaces that, advocating for better uniforms for people. If you're working on the subway system, you can't take breaks quickly if you're having a hot flash. So we have to do better in this space. And I do think that that's coming, but there's more that we can do.
For sure. One thing I know that you're very passionate about, Sheila, is the concept of contraception during kind of this stage. As a physician, I know as well, like in perimenopause and those short months or years leading up to menopause where the ovulation does stop. You can still get pregnant. And so contraception is really important during this stage. Can you talk about why this is necessary and what sort of options may be available?
For sure. So I have a couple of patients who are very kindly have offered, let me share this story. But I have a patient who was 48, hadn't had a period for a couple of months, called me and said, I think I'm in menopause. And I said, okay, we should do a pregnancy test as well. And she's like, oh, no, that's probably not happening. And now she's 56 and she has an 8-year-old child. So this is where we have these conversations where certainly your ovulation becomes less frequent during perimenopause, but it becomes unpredictable, which actually makes it very difficult to know when you might be in that fertile window. And you still can, while you are still having periods, until you have gone through 1 year without a period, you are still potentially at risk of getting pregnant. So if that's not part of your life plan at this stage, it's important to also consider contraception. And so what's really nice about contraception, and we underuse this in this age group actually, is that we can use it very safely up to age 55 for folks if they don't have risk factors. And those risk factors being high blood pressure, history of blood clots, migraines, or history of smoking. For those individuals who don't have those risk factors, we can use a low-dose contraceptive pill. The benefit of that is that, again, I'm going to say roller coaster. That roller coaster that's going up and down gets to be balanced out and comes into a straight line because we are overtaking ovulation at that stage. We're taking over the hormonal fluctuations and people just feel steadier. And so that can be really helpful, not only for contraceptive purposes, but also to steady out the hormones and help people feel better. If you are somebody who has risk factors for being on estrogen, specifically in the birth control pill, there's a progesterone-only pill, something called drospirenone. It's a newer option in Canada. It also shuts down ovulation. It's a great option as well. I use that often in my practice because that shuts down the ovulation and helps to smooth out that line of fluctuation that we see. The other option that I love is the IUD. The IUD is the Mirena IUD.
I love my
it's
IUD.
Amazing. I have
So
one
good.
too. So I don't cycle either on it, right? And what's really nice about the IUD is that it will give you a contraceptive option. It's protective against endometrial cancer. It's protective against ovarian cancer. It helps you in many ways. Also, women chronically are iron deficient because we're bleeding every month. You can have very, very heavy periods during perimenopause, especially when you have the high rise of the estrogen levels above our normal levels. And so you get a thicker lining. And so the Mirena IUD will help to reduce that lining thickness. And for many people, you don't have periods. For some folks, you do have spotting still. But for many of my patients, they're like very happy to have that instead of having an actual heavy cycle bleed.
Yeah. And what you mentioned this already, and certainly what I have heard in talking to friends who are a similar age to me as well. For me, because I have an IUD, my periods are still pretty light. But if you don't have an IUD in that perimenopause phase, I know that periods can get quite a bit heavier. And so it sounds like this is a great option for that to help, decrease that bleeding, decrease that risk of iron deficiency anemia with those heavy periods. And then just the discomfort of
I don't have time for a period
periods
anymore.
Yeah, honestly. Absolutely.
I'm very happy not to have a period and it's safe to do that. It's actually protective in many ways. It's a treatment that we use for dysfunctional uterine bleeding for folks as well. So folks who may be at higher risk for endometrial cancer, we actually use it as an option. It's used for endometriosis as well. So it helps multiple things. So I love it very much. And it actually helps. My iron has gone up as a result of being on the Mirena because I'm not having I have very heavy periods before this. And so it's helped quite a bit from that. And I notice that in my patients too. And then that's a really nice way of transitioning into menopause. Again, you may not know if you're in menopause because you're not having the regular cycling. So then we do judge it based on your other symptoms.
Right. And, speaking of other symptoms, I mean, one of the more common symptoms that I have heard about, certainly have seen situations like this in the Emerge as well, is things like palpitations, so rapid heart rate, things like new headaches, right? Because one of the things in the ER that is always a quote unquote red flag for us is someone who has a new type of headache or a new onset of headache. I know that that's something that can happen in perimenopause as well. And in these situations, you mentioned this at the beginning as well, Sheila, is the importance of having a physician provider that is following you and is, looking at things over the long term, but also ruling out other things, right? And So for me, when I have someone who comes in with palpitations, Perimenopause is going to be what we call a diagnosis of exclusion. What I mean by that is that I'm going to make sure that there is no other underlying heart issue going on, no other underlying metabolic issue like hyperthyroidism or anything like that could be leading, or like a blood clot in the lung that could be leading to these this high heart rate and palpitations. When it comes to headaches, of course, right? Like, yes, you can have benign headaches that start later in life, kind of after the age of 40. But of course, we want to make sure that there's no sort of structural abnormality in the brain. When we would do a neurologic exam, we may get some imaging to make sure there's nothing else going on. And I think that that's a really important point to keep in mind here, because many of these symptoms are new, right? They're new to us in this phase of life. And yes, the constellation of symptoms certainly could fit with perimenopause, but we always want to rule out other things first that may have different approaches or different management needs as well.
Yeah, 100%. I think I've had patients go to the emerge with palpitations, and I think that is absolutely the right thing to do because they don't know what it is. We can't just say it's a hot flash. You need to get it checked out. We end up doing a full cardiac workup for these folks again because we do notice that the cardiac risk factors, the heart risk factors go up during this time. So we have to always do due diligence for our patients and make sure that it's not just perimenopause. And I love that you included that it's a diagnosis of exclusion.
Yep.
But one that we do have to think about as well. So it's so helpful to know and have this discussion because, again, you're not at fault if you as an emerge doc, I think you appreciate when people come in and they're not sure of their symptoms because it could be something really bad. Hopefully it's not, but you never know.
And that's just it. My job in the ER, I always kind of tell people this is my job is to rule out anything bad or life-threatening. I may not have an answer for you at the end of the day, but what I can tell you is all of these things that it isn't, because for me, it's what are the life-threatening things that I cannot miss. I need to make sure that I, manage this if it is one of these things or get appropriate follow-up if it is one of these things. And what that means for me is I, see them for this discrete period of time, rule out those things, and then have, my colleagues like you in the community to kind of carry on that care afterwards once we've ruled out the life-threatening things.
We're such a good team.
Exactly. So to recap, perimenopause is natural, but sometimes unpredictable in terms of phases of life. There are, like we've talked about, multiple approaches to managing symptoms, from lifestyle adjustments to medical options, either hormonal or non-hormonal. And it's important, of course, not to overlook contraception as well.
Yeah. And I think very briefly, we've talked about contraception in a large degree of detail. If you have a Mirena IUD or something, you can actually also take menopause hormone therapy. I just want to throw that in as well, because for some folks, they don't want to be on the higher doses of contraception. Maybe they've had a tubal ligation, maybe their partner's vasectomized, like they don't need the contraception piece, and they're having hot flashes. So and they're later in perimenopause, they actually may benefit very much from menopause hormone therapy specifically, which is a different type of estrogen therapy. If you have a uterus, you always need a progesterone to balance it out to decrease the risk of endometrial cancer. If you're earlier in perimenopause, you may benefit more from a contraceptive option like a pill because you're having more of the up and down fluctuations. So actually, you want to sort of level out your hormone levels. So I think that's so important, just to kind of it can be a challenging time, but there are really a lot of options for support.
So, you've mentioned a couple of options here. So anyone who's experiencing these symptoms, where can they get help and support?
I mean, ideally, if you have a family doctor or a nurse practitioner who are open to learning with you, again, there's not very many of us yet who are fully trained to provide this care, but it is within our wheelhouse. We manage all sorts of conditions in primary care. We should be able to also manage menopause symptoms. And I think more and more people are doing this. So if your family doctor is open to it, you can go and they may not know how to prescribe yet. You can bring in some resources for them, like from the Canadian Menopause Society. They have an excellent guidebook that's a prescribing guidebook that I share with all my residents and medical students to say, this is the guidebook. This will help you treat your patients. And if your doctor doesn't know about it, you can share it with them and we can work together. If your doctor, and unfortunately the truth is that I do hear a lot of people tell me, my doctor doesn't want to even touch that area. They tell me that it's beyond their scope. You can be referred to a menopause clinic specifically. There can be long wait lists, but that is an option in different communities. You can go to the menopause specific clinics, or there's virtual clinic options that are also available that can support you through this. Ideally, it would be your family doctor or nurse practitioner, but sometimes that's not available to us and there are other options available.
So do you want to end us off with our prescription?
Yeah, absolutely.
For this episode?
So, I think our prescription for today for everybody listening is that we know that menopause and perimenopause are a normal part of aging, but suffering through it is not a normal part that we have to tolerate. We have many options for you. So please, if it's affecting your home life, your work life, your relationship with yourself or with others, please seek out support because there are options available and we're here to support you. So get help. aging is normal, suffering through it is not.
I love this, Sheila. This has been so great and so informative. Thank you, everybody, for tuning into the Doc Talk today. A reminder that the Doc Talk is for general information purposes only. This podcast is not intended to replace medical advice from your doctor. While we are doctors, we're not your doctor. Always speak to your own healthcare provider for questions related to your personal health needs. Please be sure to follow us on social media at the Doc Talk. And please send us your questions. We started out this episode with a question. We want to start off all of our episodes with questions from you. So please send us a DM and let us know what topics you'd like to hear about.
And a big thank you to Melissa Grelo for sending us the question. Give her a follow on Aging Powerfully with Melissa Grelo. And a big thank you to Always Discreet for sponsoring this episode and allowing us to speak about this.
We'll see you next time, everybody.
See you next time.